I think this will come. I think even though he's not there, I'm just going to introduce him so that we save a couple of minutes. As you all know, I'm still of the hope that he's going to continue his presentation. So Dr. Shaker, as you all know, is a clinical professor of medicine. He graduated from Georgetown University School of Medicine, followed by residency in the same place. And he finished his fellowship at UPenn School of Medicine. He joined MCW in Milwaukee in 1988, where he has remained since then after a short stint at Boise, Idaho. While his practice locations have varied from time to time, from St. Luke's to North Hills to Freighted Specialty Clinics, he has remained closely connected to our division of endocrinology here at MCW. As many of you know, he specializes in osteoporosis and calcium disorders and runs our very successful bone and calcium disorder case conference every third Thursday, which is very popular and widely attended. So he is supposed to speak on unusual cases of hypercalcemia and hyperparathyroidism, a case-based presentation. So I still haven't gotten his email. Hopefully, Herschel, one of us will get the presentation. Herschel, did you get anything yet?
No.
I introduced you, Joe. So in waiting for your presentation.
You're muted, Joe. If you're echoing like that, it means you have two apps open.
Okay, now I'm unmuted. Can you hear me?
Yeah.
Can I start the presentation? It says the PowerPoint left my outbox. I can't hear you.
Yeah, I didn't get anything, Joe.
Okay. I have it, guys. I'm going to share it.
Okay.
Good. I'm gonna mute now.
I am really sorry.
I just got it too, video.
Okay. Can you guys see? Can you guys see Joe's presentation?
Yes.
Okay. Joe, go ahead.
Okay, so and then just go forward. You don't need to introduce me. I'm old and been around a long time. Go forward.
I've already introduced you.
Oh, okay.
So, okay, well, go forward. Okay.
What I thought we would talk about is normalcalcemic primary hyperpara, hypercalcemia in pregnancy, FHH, pseudohypercalcemia, a little bit about 125 mediated, PTH related protein, some other endocrine disorders that rarely cause hypercalcemia, and a little bit about other unusual conditions. Next slide. Are there students or residents on? If not, I'm going to skip this in the interest of time. I think endocrinologists know how that calcium homeostasis works. Next one. So when we evaluate hypercalcemia, again, this is well known to the endocrinologist, we divide it up into PTH-dependent, PTH is elevated or inappropriate, and we work them up for primary hyperpara. Or if it's PTH is suppressed, it's PTH-independent, and sometimes the cause is obvious, and other times it's not, and they need to get prompt evaluation to see if they have other causes, particularly because it can be serious sometimes. Next slide. So let's talk about PTH-dependent. So this comes in a whole bunch of flavors. Obviously, the most common is sporadic, usually single gland disease, and sometimes multiple gland disease, and rarely some of these other things. MEN1, MEN2 and 3, which we're all aware of. And then there are several genes which have been labeled MEN1-like, and one which has been labeled MEN4. And MEN4 has parathyroid tumors, pituitary tumors, adrenal tumors, renal tumors, and gonadal tumors. And then the very important hyperparathyroid jaw tumor syndrome, which has cystic adenomas, parathyroid carcinomas, perhaps 25% of the primary hyperparas, renal tumors, and uterine tumors, which are sometimes malignant. Next slide. And of course, familial isolated hyperparathyroidism. These are cases that are sometimes difficult to sort out. We find that mom, an uncle, and the patient that we're seeing has primary hyperpara. We know there's a familial condition. We know it's probably genetic. And studies show that about 30% of those have mutations of either MEN1, calcium sensing receptor, or CDC73. More recently, the glial cell missing 2 gene, which has been associated both with autosomal recessive and autosomal dominant hypoparathyroidism. Recently, gain of function mutations have been associated with a significant percentage of those FIH patients without mutations of the other 3 genes. And I'm sure some of those MEN1 like genes are also in some of the families, and I'm guessing there's others. Also PTH dependent, or FHH, something called autoimmune hypocalciuric hypercalcemia, lithium associated hypercalcemia, and rarely ectopic PTH. Next slide. So I will just mention this. I have never recognized a case of ectopic PTH, but there are several single case reports in the literature of various tumors producing actual PTH with various degrees of proof. Sometimes it's really well proven with, looking for gene expression or mRNA or staining for the peptide, and sometimes it's less well proven. Next slide. So the typical primary hyperpara, as you're all familiar with, has a mean calcium of 10.6 to 10.8 with a high normal or high PTH, high normal or high urinary calcium. Some also have intermittent hypercalcemia, and they're usually adenomas and sometimes multiple gland disease. And typically we diagnose it with a high calcium, higher inappropriate PTH, and normal to elevated urinary calcium. Well, how about this normalcalcemic variant? High PTH with normal calcium. Next slide. Well, I suppose the first question is, why do we care? So primary hyperpara is associated with bone deficits. Now, we used to think they were just cortical based on standard bone densitometry, but in recent years, it's clear that there are trabecular deficits when you look at bone with fancy techniques, such as high resolution peripheral QCT, and that both fractures at cortical and trabecular sites, such as spine fractures, are increased in these patients. There's kidney stones. Perhaps 17% of patients with hyperpara have stones, even if they aren't aware of them. And then, of course, the non-classical symptoms. Mortality appears to be increased in those with severe disease, but not those with mild disease. And then, of course, there's the controversy about whether cardiovascular disease and hypertension are reversible. Clearly, there's an association, but are they reversible? And depression and neuropsychiatric symptoms, again, controversy, depending on what study you look at, whether it's randomized, where there appears to be less effect, or observational, where there appears to be more effect. I can tell you from my perspective, when patients have a lot of neuropsychiatric symptoms, I do generally recommend surgery, but I try to manage their expectations and tell them there's about a 50% chance things will get better. Next slide. So I want to start with some definitions before I talk about normalcalcemic primary hyperpara. Typical primary hyperpara, hypercalcemia or intermittent hypercalcemia with high or inappropriate PTH due to autonomous parathyroid tissue. Secondary hyperparathyroidism has a normal calcium with an elevation in PTH that is a physiologic response, like chronic kidney disease. Normalcalcemic is persistently normal, corrected calcium and ionized calcium with persistently elevated PTH due to autonomous parathyroid tissue. And the latter two, secondary and normalcalcemic primary, are difficult to diagnose, to differentiate, recognizing that secondary is way more common. Next slide. So let's start with a case. This is a 62-year-old man. He gets some kind of x-ray. They find compression fractures. His bone density is really low. His calcium and D intake are good. He has no stones, nothing to suggest syndromic hyperpara. And his calciums are 9.2 and 9.3, the PTH about 80, phosphorus low normal, 25D normal, his ionized calcium dead normal, urinary calcium 129. They had done celiac serology and a small bowel biopsy. They were negative, and he was scheduled for surgery at a famous institution. Next slide. So it makes sense that there might be normalcalcemic primary hyperpara. I wish I could use a pointer, but basically, the intra-individual variation in calcium is much less than the variation among a population. So in an individual, their calcium might typically be 9.2 and range tightly around that. And an increase up to 9.8 would be abnormal for them. So theoretically, it makes sense that there could be people whose calcium is still in the normal population range. Next slide. So what might be normalcalcemic? So there are clear criteria and exclusion criteria. The patients have to have multiple elevated PTH level with persistently normal albumin-corrected and ionized calcium. If you exclude patients with elevated ionized calcium or intermittent hypercalcemia, a big chunk of them go away. You need to rule out secondary hyperparathyroidism. You need a vitamin D more than 20 and preferably more than 30, and recognize that the PTH may stay elevated for a long time after D repletion. Need a GFR more than 60. I'm going to say that again, a GFR more than 60. So when you make this diagnosis in an 80-year-old, you probably can't, because their GFR is usually not more than 60. You need to consider medications that can raise the PTH. And I'll point particular attention to denosumab. I have seen several patients who've been diagnosed with osteoporosis, started on denosumab, and then when a PTH is done a few weeks after a dose and is elevated, referred for hyperparathyroidism, sometimes to surgeons. And in one case that I've seen, inappropriate surgery was done. You need to consider diseases that can increase the PTH, like Paget's or osteoblastic metastases, and in particular, rule out malabsorption, celiac disease, or bariatric surgery. I don't think you can make a diagnosis of normalcalcemic primary hyperpara in someone who's had a gastric bypass. You need to exclude marked hypercalciuria. This is in the criteria. So if they got a urinary calcium of 500, what they might have is renal leak hypercalciuria with secondary hyperparathyroidism. Next slide. So what happens if you follow those patients? Well, some become hypercalcemic. Well, that's great because now you have a diagnosis. Bone loss is common, but that's often why the PTH was done. Other observations, less likely to image positive, 2 to 3 times more likely to have multiple gland disease than the general population, smaller adenomas, and there really isn't long-term follow-up after surgery available. There is some follow-up that suggests increased bone density, but we also know bone density improves with anti-resorptive therapy. Next slide. So this is an interesting study. It's from Italy. They looked at about 5,000 patients, 6,000 patients who had bone densities. And in that population, the green marks 2.7% that had primary hyperpara. The red are people that had either low vitamin Ds or low GFR, and therefore were classified as secondary hyperpara, 4.5%. And then they found 0.5% with what initially met the criteria for normalcalcemic primary hyperpara. But they excluded 15 of those for other medical explanations. Only 4 had consistent normalcalcemia, and only 2 of those had persistent elevation in PTH. And if you look whether any had persistent adequate D and adequate renal function, they didn't, suggesting it's pretty uncommon. Next slide. This is another study from Italy. And one of the things a little weird about this is I couldn't find from that study why the PTH was obtained. and you'll see why that's important in a minute. They compared roughly 40 patients with what they diagnosed as normalcalcemic primary hyperpara to the same amount of controls and hypercalcemic primary hyperpara. And they defined these patients with normalcalcemic as having at least 2 normal corrected and ionized calcium levels and PTH levels at least 3 months apart. They had to have an eGFR of greater than 60, a vitamin D of greater than 30, and they excluded other secondary causes. Next slide. In that population with normalcalcemic, they had similar PTHs to the hypercalcemic, lower calcium and higher phosphorus. But interestingly, their bone density was similar to the normals, not to the primary hyperparas. And if you look at the table below, they looked at morphometric vertebral fractures by VFA. And what they found was that the normalcalcemic primary hyperparas were no different than the controls with respect to vertebral fractures or moderate to severe vertebral fractures. The people with hypercalcemic primary hyperpara had much more. So they were skeletalized. This population, who wasn't chosen by bone density, was similar to people who did not have primary hyperpara. Next slide. So this guy goes to the famous institution, has 3 glands removed, and post-op his calcium is 9.1 and 9.3, and his PTH levels are still elevated at 70 and 105. That's a problem. Next slide. So he goes to another institution, another famous institution, and they said, the diagnosis was wrong. You never had normalcalcemic primary hyperparathyroidism. Next slide. So how about this issue of elevated PTH after curative parathyroid surgery? On the left of your slide is a study from North Carolina. And they looked at patients, about 150 or so, who had parathyroid hormone levels 3 to 18 months after curative parathyroid surgery. Now, it's important to note that another big chunk of patients didn't have that done, but those 2 groups were not different in any way that you could see. And of the patients who had them, 30% had elevated PTHs at 3 to 18 months. This is a slightly different study from Michigan, where they found in the red circle, 11% had persistent elevation in PTH after normalization of the calcium. So next slide. So the PTH may remain elevated after surgery in hypercalcemic primary hyperpara, but they've become normalcalcemic. What are you going to do when the patient has normalcalcemic primary hyperpara? So if the only need for surgery is bone density, you could consider a drug. If the only need is hypercalciuria or stones, you could consider a thiazide and see if the patients become hypercalcemic. In my opinion, this diagnosis should be made very cautiously, and they really need to see someone with expertise. And I am generally favor observation in these patients. Next slide. So this is from a review last year by Dr. Zavada and Bart Clark from the Mayo Clinic in JBMR Plus. And I just want to read to you their conclusions. A precise definition has been derived by the consensus, but prospective studies are needed that include these patients. The pathophysiology may be heterogeneous. It's a diagnosis of exclusion because long-term follow-up frequently reveals that the parathyroid hormone normalizes. The natural history is unknown, and their biggest conclusion is caution should be used in recommending surgery for normalcalcemic primary hyperpara, but when surgery is done, multiple gland disease has been reported. That bothers me. This sounds like it's different than typical primary hyperpara, and I am not an enthusiast of surgery in these patients. Next slide. So let's move on to FHH. As you know, this is asymptomatic, modest, lifelong hypercalcemia. They have a low urine calcium and usually have a low calcium to creatinine clearance ratio less than 0.01. The PTH is normal and sometimes elevated. Magnesium is highish. It's autosomal dominant. You don't want to do surgery because there are only two outcomes: hypoparathyroidism or persistent disease. Next slide. Most of these patients have mutations of the calcium sensing receptor, and they don't sense calcium right. If you inherit 2 copies of this gene, then there's some people get neonatal severe hyperparathyroidism. Next slide. So I want to move to a patient who's pregnant. She's 36 years old. It's her first pregnancy. She's 24 weeks pregnant. 4 years earlier, she was diagnosed with primary hyperpara. Her calciums were about 11. PTH is high normal. Urinary calcium 239. Because of her age, they did genetic testing, and CDC73, MEN1, and calcium sensing receptor mutations were negative. She had a single gland removed. Intraoperative PTH responded the way it's supposed to, but hypercalcemia persisted. Next slide. Now, her calcium is about the same. Her PTH is normal but inappropriate. Her urinary calcium was 226 shortly before the pregnancy. What should we do next? Second trimester parathyroidectomy. Next slide. So there are significant complications of hyperpara in pregnancy. For the mother, stones, bone disease, pancreatitis has been reported in pregnancy, hyperemesis gravidarum, preeclampsia, hypercalcemic crisis. And there's also fetal complications, prematurity, neonatal hypocalcemia because the parathyroids in the fetus are suppressed, stillbirth and miscarriage, intrauterine growth retardation, and low birth weight. Next slide. So typically the management is second trimester surgery, with the caveat that patients with very mild disease appear to generally do okay. I think if you have a calcium at 10.5, you may not need to have surgery, although they may have increased preterm delivery and preeclampsia. But because of the age, they should have genetic evaluation, right? So next slide. So let's go to this patient. So even though her urinary calcium was in the low 200s twice, her calcium to creatinine clearance ratio was 0.008 once and 0.012 the first time. And genetic testing revealed a pathogenic variant in AP2S1 gene, which causes FHH3. Next slide. It's important to remember that there are at least 2 other genes that cause FHH, and I've listed the FHH2 and FHH3 genes here. FHH3 in particular can cause more severe hypercalcemia. I have a patient with that whose calciums range between 12 and 13. Surgery, again, is not an option because there's only 2 potential outcomes, and they may respond to cinacalcin. So the bottom line is not all FHH have calcium sensing receptor mutations. Next slide. So I think we need to decide who needs to be screened genetically. And this is a study where they looked, these patients, 54 patients, all had proven FHH1, and they compared them to roughly 100 primary hyperpara. And the calcium to creatinine clearance ratio of less than 0.02 picked up 53 of 54 of the FHH. If you used 0.01, you missed 20% of the FHHs. The problem is that a third of the primary hyperparas are less than 0.02. But sensitivity is really important. You don't want to operate on FHH. Next slide. So this is the basis for the guidelines that came in 2014. They say if the calcium to creatinine clearance ratio is less than 0.01, with the caveat you have to have adequate vitamin D and adequate renal function. It's probably FHH. Usually do genetic screening to confirm and to facilitate family testing. If it's between 0.01 and 0.02, you need to do the testing. I think you do generally need to do that. I do look at old calcium levels. This is not an acquired disease. I look at family calciums if I can, but you need to screen for all 3. And you know, I've heard people say, well, if the urine calcium is greater than 100, I don't worry. If it's greater than 200, I don't worry. I don't think that's true. I think, as my last patient showed, her urinary calciums were in the 200s. But if you did the calculation, it came out in the range where genetic testing should be done, particularly given the young age at presentation. Next slide. So I want to mention autoimmune hypocalciuric hypercalcemia. This looks just like FHH, but it's acquired, and they don't have a family history. They don't have mutations. There are a handful of cases reported. They have autoimmune disease, and they have antibodies to the calcium sensing receptor. For the most part, they probably don't need treatment if the calcium is only modestly elevated. Steroids have been shown to work, but I think I'll take a modest level of hypercalcemia over corticosteroid therapy anytime. Next slide. So as long as we're talking about genetic testing, I want to talk about when should we do it in general. So this is a study where they looked at 86 patients under the age of 45 with clinically non-familial, non-syndromic hyperpara. And 9% had germline mutations of MEN1, CDC73, or calcium sensing receptor. So I think this is why the guidelines are as follows. Next slide. So this is who's supposed to be screened. They say, is it syndromic? Do they have anything to suggest one of these endocrine syndromes? Do they have a family history? Are they less than 45 years old at diagnosis? Do they have parathyroid cancer or atypical adenomas? Or do they have multiple gland disease? And if they have any of these, genetic testing is advised. Now, they talk about sequential testing, but now we don't do that very much because we have these panels that are much cheaper to do than trying to do sequential testing. And the one we send out does 7 genes. So these patients should be tested for genetic disease. Next slide. Okay, I'm going to change the topic. This is a 90-year-old. She's hospitalized with heart failure, anemia, confusion, and hypercalcemia. She's very thin. She's confused. Next slide. Her calcium is 12.5, creatinine 1.2. Her albumin's low. Her corrected calcium is 14. Her vitamin D is a little low, PTH a little high, and urinary calcium normal. Is this primary hyperpara? Next slide. And you look at that calcium and PTH, and you might say, yeah, it looks like primary hyperpara. Next slide. Her ionized calcium was normal. And this person had myeloma, and she had pseudohypercalcemia due to binding of calcium to the abnormal immunoglobulin. And the elevated PTH was just due to age, chronic kidney disease, and low vitamin D. So you can see pseudohypercalcemia with high serum albumin, thrombocythemia, which basically causes an in vitro release of calcium, and with calcium binding to M proteins. There's controversy about whether you should correct the calcium for albumin when it's above 4. The renal guidelines say don't, but that makes no sense to me at all. Obviously, there's a relationship between the higher albumin and higher calciums. We've all seen many, many patients who have albumins of 5 and calciums of 10.4, and whom the ionized calcium is dead normal. And I don't know, obviously the relationship is probably not the same linear relationship, but there's some relationship. So I do recommend correcting them. Next slide. So when can the PTH be misleading? So you can have a low PTH in primary hyperpara if you have an assay problem. And the most common thing we know about is high dose biotin, which causes artifactual low PTH. Primary hyperpara with superimposed secondary hypercalcemic condition, and the calcium exceeds the set point. So you have hyperpara with a calcium of 11. You get sarcoid, it goes up to 13. The PTH goes down because that adenoma has a set point. I've seen it misdiagnosed because they were getting cinecalcet and the blood was drawn shortly thereafter. there are reports with PTH gene mutations that don't measure on the assay. And you can also get high calcium with inappropriate PTH that's not primary hyperpara. For example, anti-murine heterophile antibodies, ectopic PTH, pseudohypercalcemia, and some of the other things we've discussed. Next slide. So I want to move on to PTH-independent hypercalcemia. I won't go through this slide because I think people know most of these things, and I'm going to go through the important unusual ones independently. Next slide. So this is a 27-year-old woman. She's pregnant. She has episodes of severe hypercalcemia requiring admission. She did have a pregnancy 7 years earlier, and she had no calcium levels during the pregnancy, but 1 month postpartum, she had a kidney stone and a calcium of 13.8 with a suppressed PTH. And then between the pregnancies, had 2 subsequent normal calciums. She had no unusual ingestions, and everything else was essentially normal. Next slide. Her PTH was suppressed, 25D normal, SPEP, phos, creatinine normal, urinary calcium markedly elevated, PTH-RP undetectable, 125D level very high, but ACE and ANCA were normal, cortisol was normal, a chest x-ray was negative, and she'd even had an MRI, chest, abdomen, and pelvis, which were negative. Next slide. So you're considering all these things that cause calcitriol-mediated hypercalcemia. I'm not going to go through these. Obviously, sarcoid and lymphoma are the most important things in our practice, but there's this long list of granulomatous and inflammatory disorders that can cause it that I always have to look at when I have weird cases. Next slide. So she had no response to prednisone. That argues against a granulomatous or inflammatory condition. And there was no evidence of lymphoma. Next slide. So could this be deficiency of the enzyme that breaks down 25D and 125D? Next slide. So if you look on kind of the left of your slide, you'll see an arrow going down to 24-25D, and that enzyme is called CYP24A1 or 24-hydroxylase. And it also, on the right side of the picture, takes 125D to an inactivated 124-25D. Next slide. Well, she turned out to be a compound heterozygote for mutations in that gene, and she was managed with hydration. And her hypercalcemia was really difficult to manage until we got her to stop nursing. During nursing, she would sometimes get calciums of 13. And after nursing, her calcium normalized. Her PTH became low normal. Her 125D was still high, and urinary calcium still markedly elevated. Next slide. So mutations in this cause infantile hypercalcemia, adult hypercalcemia, and also hypercalciuria and stones. Most are homozygotes or compound heterozygotes, but there are some dominant inheritance. These are patients you do not want to give vitamin D2 because you can make it worse. Next slide. So what's been reported is it gets much worse during pregnancy. We've observed that it's worse during lactation, and also in patients it can be extremely labile and sometimes severe. You treat them with hydration, calcium and D restriction, and sunscreen, and ketoconazole, fluconazole, and rifampin have been used, but they're not without toxicity. Next slide. So why the hypercalcemia during pregnancy? Presumably 125D production by the placenta. And why the hypercalcemia during lactation? Remember that these patients get intermittent elevations in PTH-RP. We measured it once in that patient and it was normal, but I don't know what that means. Next slide. So let's talk about PTH-RP. PTH-RP was predicted in 1941 by Fuller Albright in a CPC in the New England Journal of Medicine. Now we take it for granted. Obviously, it causes a lot of the humoral hypercalcemia malignancy. It has N-terminal homology with PTH. It's not measured on our assays. It's in high concentrations in breast milk, and it's important in fetal development. Next slide. In this study, they found that they looked at 138 patients with PTHRP-related hypercalcemia. And the interesting thing was they found that about 8 or 9% were from benign conditions. And so we have to recognize that there's also something called the hypercalcemia of benignancy, which some people have labeled it. Next slide. And again, this is a list of conditions which have been reported to cause that. And there are varying degrees of quality of proof. But just to recognize it can occur in benign conditions. Next slide. So I want to talk about medications a little bit. I'll talk about lithium and thiazides. Let me just mention PTH and abaloparatide therapy. If you measure the calcium an hour or two after it, it's often a little high. I tell my patients to make sure they do their blood work at least 12 hours after these injections. Next slide. So lithium changes the set point for PTH, resulting in a higher calcium required to lower the PTH. And it may have a similar effect on the kidney tubule, and you can get a hypocalciuric hypercalcemia. The interesting thing is surgery in these patients, a much higher percent have multiple gland disease, persistence and recurrence are increased. It doesn't just go away with lithium cessation. And obviously many of the patients can't stop lithium. Next slide. Thiazides. This is a common clinical problem. What do? Well, they decrease urinary calcium excretion. They cause a little volume contraction. They may unmask hypercalcemia. There's a study from the 60s in rodents that suggests thiazides induce parathyroid gland enlargement and increase PTH. That's never been replicated in humans, and I don't know if that's true. What is true is that most patients with thiazide-associated persistent hypercalcemia have an underlying hypercalcemic disorder. Next slide. This is the way I approach them. If the PTH is suppressed, you could have serious pathology. So I would stop the thiazide and evaluate them. If the PTH is high or inappropriate and the hypercalcemia is mild and stable, and you're not going to recommend surgery, then I don't think there's any need to stop it. Just monitor the calcium. If the hypercalcemia is significant and you're considering surgery for the patient, I would stop the thiazide and evaluate the patient. Next slide. So I want to finish with a few unusual things. The milk alkali syndrome, which is due to excessive ingestion of calcium and base. In the old days, this is how they treated ulcers. They had people drink milk and cream all day and take soda bicarbonate, so the so-called SIPI regimen. Now, it's mostly patients who are either surreptitiously or intentionally taking too much calcium carbonate or TUMS. They have hypercalcemia, metabolic alkalosis, acute kidney injury. These patients need follow-up, though, because I've seen a few of them where if you follow them, you stop everything, and they turn out to have mild underlying hyperpara. After everything is stopped, 6 months later, their calcium is 10.5 and their PTH is 80. And the PTH suppression during the severe hypercalcemic episode is because calcium exceeds the set point of the autonomous glands. Next slide. Hyperthyroidism. Mild hypercalcemia is not rare. Severe hypercalcemia is uncommon. It's increased bone resorption more than formation, and they have low PTH and 125D, as well as hypercalciuria, and they can have high alk phos. I have seen patients come with bone scans and everything for high alk phos when the diagnosis was just Graves' disease. Next slide. So let me move on to a patient. This is a patient that Dr. Finling sent me. It's a 57-year-old woman with multiple compression fractures. He diagnosed her with occult ectopic ACTH. She had bilateral adrenalectomy and was put on hydrocortisone and fludrocortisone. Preoperative, she was normalcalcemic, but 3 weeks post-op, her calcium was 10.5. 4 months post-op, her calcium was 12.8. She had high urine calcium. The PTH was suppressed. PTH-RP and SPEP were okay. The 125D was kind of high-ish for the ambient conditions. ACE level was normal. She had extensive imaging already done, and she responded to IV bisphosphonate. Next slide. So how about hypercalcemia with adrenal insufficiency? This has been reported in Addison's. It's been reported in steroid withdrawal. It's been reported after cure of Cushing's, like in this patient, and with isolated ACTH deficiency, although some of those patients also had thyrotoxic thyroiditis at the same time. They may have acute kidney injury. The mechanism isn't completely clear, but I think volume depletion could be a factor, and perhaps excess production of 125D for reasons that aren't entirely clear to me. Next slide. As long as we're talking about the adrenals, how about pheochromocytoma? They've been reported with hypercalcemia from multiple causes. PTH-related protein has been reported from pheos. Ectopic PTH has been reported. And catechol-induced increased bone resorption has been reported. Obviously, if you have a pheo in a patient who's hypercalcemia, you want to make sure you avoid confusion thinking about MEN2 in a patient with a pheo and primary hyperparathyroidism. Next slide. This is something which I think I've seen, but the reason for it is completely unclear to me. Patients with very severe liver failure can occasionally get PTH-independent hypercalcemia, which does not appear to be related to 125D or PTH-related protein, and it's a diagnosis of exclusion, and there are cases reported in the literature. Next slide. So this one is one that's become a little more important recently, and that's DMAB withdrawal. I have seen that once. So as you know, when you stop denosumab, some people get a rebound increase in bone resorption, and I think most of you know about the increased risk for multiple compression fractures, and that you just can't stop this medication. Well, most of the cases of hypercalcemia are reported in children where they have already an underlying disorder of increased bone resorption, such as giant cell tumors and fibrous dysplasia of bone. And in fact, some of these cases have been life-threatening hypercalcemia requiring hospitalization. Next slide. So how about immobilization? We talk about this in the hospital sometime. Usually it's other factors too. But remember that the skeleton senses a mechanical pressure. And when you are unloaded, you increase bone resorption and decrease bone formation. The most common setting is spinal cord injury in young males. They have low PTH and low 125D, hypercalciuria, and it does respond to bisphosphonates. Of course, NASA is very concerned about this, not the hypercalcemia so much as the bone loss that occurs when people are an extended space travel, for example, on space station. Next slide. So I'll mention one more very interesting cause of hypercalcemia in infants and young children, and that's Jansen's osteodystrophy, or Jansen's metaphyseal chondrodysplasia. This is a short-limb chondrodysplasia, which is due to gain of function mutation of the PTH1 PTH-RP receptor. So it's as if PTH is unchecked. They have hypercalcemia, and activity of that mutation is what causes the osteodystrophy. And it can be autosomal dominant, but most are spontaneous mutations. Next slide. So let me just kind of summarize, and hopefully I've left a few minutes for questions. Divide hypercalcemia into PTH dependent and independent. Most cases of PTH-dependent are straightforward. The diagnosis of normalcalcemic primary hyperpara should be made with caution. Secondary hyperpara is much more common, and I am very conservative about surgery in these patients. Don't be shy about getting genetic testing in primary hyperpara. I noticed that people are like reluctant. You know, there are guidelines out there. Send the patients to the genetic counselors. They're 40 years old, just send them. You know, we worry about the cost that we do when nobody thinks twice about ordering a $4,000 MRI for back pain. So follow the guidelines. Next slide. Occasionally, the PTH can be misleading. I think the biggest issue is biotin or hair and nail products. Unexplained PTH-independent hypercalcemia needs prompt evaluation because it could be something serious. There's a long list of things that cause calcitriol-induced hypercalcemia, and they keep adding things to it. But I think in those who look like they may have lifelong hypercalcemia, you need to look at this CYP24A1 mutations. PTHRP can also cause hypercalcemia of malignancy. Next slide. Think about the meds, and in particular, don't forget denosumab withdrawal. Then the endocrine conditions, hyperthyroidism, adrenal insufficiency, and pheochromocytoma. And then, of course, some miscellaneous conditions that I mentioned at the end. Next slide. Thank you, and I apologize for the technical problems. I don't know what the block on my computers are, but something kept me from getting in. So thank you very much, and I'm happy to answer questions.
I'm going to stop sharing the screen. So you can also put the questions in chat box. So if you have questions, while we're waiting, can I ask a couple of questions, Joe?
Sure.
So, and you said severe liver failure. I have a patient one. The only cause I have is liver cirrhosis. When you say severe decompensated, can it be just cirrhosis, or does it have to be like, they have ascites and all that? What do you think?
And the only thing I know about this is the one patient that I've seen and the few patients I've read about in the literature. The one patient that I've seen was pretty advanced. She was being listed for transplant, and I could find nothing else to explain it. And the other patients in the literature that I've seen were pretty severe. Now, I don't know if just cirrhosis without, liver failure could cause it. Or, yeah, I don't know. It might be. It's hard to know because we don't know the mechanism.
Right, exactly.
I mean, is it something else that's coming out of the liver that activates bone resorption when it's that sick? I don't know. I have no idea.
Joe, I wanted to share that I have seen recently a patient who had liver transplant, and within 6 months of the liver transplant, she also developed an unusual hypercalcemia. So do you have any thoughts about hypercalcemia after liver transplant?
I don't know the answer. I mean, is it PTH dependent or independent or?
Independent. PTH was 8, and I'm repeating. So I just saw her, so I'm repeating everything.
Yeah, I mean, I don't know of any specific thing. I can think of one thing that pops to mind is, as I recall, the liver transplants, they get off steroids. So she might have steroid withdrawal. I'm guessing, is she off prednisone?
Yes, she was.
So that's theoretically one possibility. Other than that, I would look for corruptive like any other patient, I think, because nothing else pops to mind that a liver transplant would cause. Other than that, I don't know if somebody else has some ideas. That's a question. I mean, I would do the 125, the SPEP, the PTHRP, and just like anyone else, the urinary calcium.
Yes.
And the renal function is okay?
Yes, renal function is good. She just started on her transplant medications about 6 months ago. So renal function is good, and I'm just waiting for all the labs I
Yeah.
ordered all that, including SPEP and UPEP. And she's young, she's only 42. And the diagnosis, the reason for her liver failure was alcoholism, but she quit drinking about a year and a half ago.
And she was clearly normal before.
Yes, she had normal calcium levels until February. So once we see in February is that she started peaking her calcium levels progressively from mild 10s to 11s.
Interesting. Now, so the one thing I would add to the differential diagnosis is steroid withdrawal, because that has been reported.
That's a good thought.
There is a question in the chat box. Are there alternate forms of PTHRP that are not detected in the standard assay?
So I saw Herschel put that in. The short answer is I'm guessing yes, but I don't know that. You know, there's alternate forms of everything, right, Herschel?
I would say yes. So, one more question. When you say, we see a lot of patients with this immobilization type of, at least we guess immobilization as cause of hypercalcemia. How immobilized do they have to be? When what I understand, they have to be pretty immobilized, like, paraplegia, quadriplegia types, right? But, these mild, paraplegia doesn't cause it, right?
So they have to be at bed rest, or like you said, paraplegia or quadriplegia. It's not someone who's oh gee, I can only get up to go to the bathroom twice a day. It's not that. It's people that are really immobilized. And I think sometimes, in a hospital, someone's in the ICU and maybe they have underlying primary hyperpara that no one really looked and realized, well, gee, if you go back there, calcium's 10.3, 10.4, 9.8, 10.4, bounces around there. And then they're in the ICU for 3 weeks, and then they are at bed rest, and all of a sudden the calcium's 11 or 12. And we have to look at what they're given at TPN too. And so you have a whole bunch of things that end up contributing to it. And I think,
no, thank you. I think it does really come up a lot in the hospital, non-PTH mediated hypercalcemia cause. I have one last question, if no one else, I don't see anything in the chat box, and no raised hands either. So, I just recently saw a patient with hypercalcemia. The patient actually has sarcoidosis. So when they initially saw the patient, the PTH was 8. The 125D was elevated, so they considered it as sarcoid, and they were treating it. And then recently, someone measured the calcium is again a little bit elevated, but now the PTH is 60 or, it's up. It's elevated now up to 70. It's still in the like a little bit higher normal. But the patient is on steroids, 10 milligrams. So my thought was that, the calcium is not as high as before, but still quite elevated on prednisone. So is this the recovery phase of these patients who are sarcoid? What does their PTH do when they give them steroids?
so I would argue that if the patient has normal renal function, a PTH of 60 in the presence of true hypercalcemia is inappropriate. So I would really wonder that the patient has an underlying parathyroid disorder. And I guess it would follow as they cut the steroids down. How high is the calcium now?
So it was somewhere between 10 to 11, and so it's like 10.5.
Yeah.
So he went up to 11 when the PTH was, in fact, maybe even 12 at one point when the PTH a couple of times was 8. So they were treating it, with the steroids.
Yeah. So you wonder if the patient has underlying primary hyperpara too.
Okay.
And then you loaded at sarcoid, and that, that's what I would think. I don't know, Denise, what would you think? Anything different?
Agree with you, Joe.
Okay. Yeah, I didn't know exactly. It's not that common that I see sarcoid-related hypercalcemia, and I didn't know what the PTH does when you treat the sarcoid, whether it goes the other way for a bit.
I would think only if your calcium gets
Normal.
really normal or lowish. I can't see why it would make sense for it to get high if your calcium is still truly elevated, particularly if the ionized calcium. It doesn't make sense to me. But clearly, the PTH normalizes when you adequately treat those. And a lot of these patients with sarcoid, you can treat with, you start with a significant dose of prednisone, you can get them down to very low doses and maintain the calcium. One other comment about calcitriol-induced hypercalcemia for the fellows is that the calcitriol doesn't have to be frankly elevated. It can be inappropriate. If it's 45 in a person with high calcium, no PTH, and no PTHRP, that's inappropriate. Just like if you saw a person with Cushing syndrome and an ACTH of 50, you wouldn't say, oh, gee, it can't be Cushing's disease because the ACTH isn't elevated. It's inappropriate. So I think you have to think of 125D with respect to the ambient conditions, and that'll give you an idea for what it means. I think you're muted.
Joe,
Go ahead.
in calcitriol-mediated hypercalcemia, a couple of our fellows presented within the last month 125 dehydroxyDs that were almost 300. Have you seen levels that?
Not often. I've seen pretty high levels. I don't remember what the highest was, but that's pretty high. Do you know what the patient had?
No, one of the cases was presented today during their case presentation during the conference. But for me, that was a pretty high level. One of the patients was presented a week or two ago with calcitriol-mediated hypercalcemia. The other one, the one that was presented today, is having a high PTH, high calcium of 13, and the working diagnosis has been primary hyperpara, but that 125 level is pretty high. I've never seen a primary hyperpara patient with a very high 125 dehydroxyD level.
Yeah, so I would argue that that's higher than typical, but the average 125 is at the high end of normal. I would have never checked it. If I would have made the diagnosis of primary hyperpara and not 125D. But now
I don't routinely check when I suspect of primary hyperpara, right? So I'm suspicious that this patient might have something else besides primary hyperpara.
Well, the good news is that, did they image the patient yet for the parathyroid?
No, I don't think. One of our fellows, I think, will be able to expand more. So it's with patients, but the patient has not been imaged.
Yeah, I have to say that's probably distinctly unusual, but I don't do it enough in patients with severe hyperpara to know. But you might be right that there might be apples and oranges. I just don't know how you'd sort it out without curing the hyperpara first. And the PTH is very high or just a little high?
Uso, are you still there? Maybe she can.
PTH is 582.
Is what? 582? Yeah, I'd be worried about parathyroid cancer too.
The PTH was 582.
And normal renal function, I assume.
Yes.
I'd be worried about parathyroid cancer. I can tell you that.
Yeah.
Or it's at least an atypical adenoma. But the patient should be managed probably quickly. I think I'd handle that first and see what happens to it.
Okay. Sounds good.
Thank you, Joe. Thanks, everyone, for a
Really
wonderful presentation.
Thank you, Joe.
Thanks, Vidya, for doing the AV.
You're welcome.
Take care.
Bye.